Good morning. Happy this morning to have a new member in the Cancer Immunology program, Dennis Moledina, speak. I'm Marcus Bosenberg, one of the co-leaders of the Cancer Immunology program. And Dennis has done much of his training, at least in the postgraduate medical side, at Yale, and has been an assistant professor at Yale, and has been very successful in generating funding and results looking at kidney disease. And I think this is one of the wonderful things about, it's not a wonderful thing for patients, but it brings a larger portion of the medical community together with these immune-related adverse events, including specialties like endocrinology, nephrology, and cardiology into the cancer fold a bit more. And we're obviously very interested in having their help and also in managing these patients. And Dennis will be, he's also completed the investigative medicine program at Yale, which I think is really a flagship in trying to generate more physician sciences. And Dennis is really a shining example of that. And so Dennis today will be talking about biomarkers for non-invasive diagnosis of acute tubulointerstitial nephritis. And we're looking forward to your talk, Dennis. Thanks.
Thank you, Dr. Bosenberg, for the kind introduction. It's a nice intimate group. I don't mind being interrupted at all. So if you have questions, speak up. Even for the Zoom world, I can't really see the chat, but if you have questions, I totally don't mind being interrupted. So what I'll talk to you today about is something that I worked on for the past 8 or 10 years, which is trying to find biomarkers or diagnostic biomarkers specifically for acute tubulointerstitial nephritis. And because of immune checkpoint inhibitors and immune-related adverse events, I've sort of stumbled into this cancer world, and I'll talk to you about a project that we're starting off. My disclosures, I have a pending patent with my mentor on methods and systems for diagnosis of interstitial nephritis. We have a company that tries to commercialize some of these biomarkers, but we don't have any product yet. I have grant support studying this. I received honoraria and some consulting here. General outline for the talk. First, I'll just give you a little background on interstitial nephritis, why we need biomarkers, what's the problem. We'll talk about current diagnostic testing available in interstitial nephritis. Then I'll jump into AI and biomarker. A lot of the work that's been done by our group is on AI and biomarkers. And then very briefly on ongoing projects with the larger goal of getting these biomarkers to our patients at the bedside. So what is interstitial nephritis? So to us nephrologists, interstitial nephritis is a histologic diagnosis. It's characterized, so if you see, this is the normal tubular interstitium. I'm not showing any glomeruli, but I'm just showing you the tubular interstitium, which forms a chunk of kidney when you look at it under the microscope. This is a very healthy tubule, with these tubular cells looking quite healthy. They're back to back. There's no real gap between them. There's a few scattered immune cells, but not really. Renal pathologists won't describe any immune cells, at least in H&E under light microscopy. This is what interstitial nephritis looks like. So it's characterized by these tubules that get separated from each other with interstitial edema here. And this space is taken up by a lot of immune cells. This is a characteristic finding of interstitial nephritis. These immune cells end up crossing this tubular basement membrane and entering into the tubular space. So which pathologists call tubulitis, and the combination of infiltrate and tubulitis to most pathologists is interstitial nephritis. Often, but not always, there are eosinophils. So there are specific drugs that cause interstitial nephritis with eosinophils in it, and there are many that cause without eosinophils. So if you see eosinophils, it kind of tells you it's a specific type of drug that causes, such as antibiotics. Well, the past couple of decades, folks have done work in trying to characterize what these cells are to me, at a very sort of high up level, in that we know that these cells are CD4, CD8 positive T cells, most of them, 80% of them. There are 10 to 20% macrophages, and then we and others have shown that there are a fair number of mast cells in here too. We don't know the actual prevalence of interstitial nephritis because it's a histologic diagnosis. What we know is that 2 to 3% of all kidney biopsies have interstitial nephritis as the diagnosis. But if you restrict the analysis to biopsies with acute kidney injury, so loss of kidney function, almost 1 in 5 have interstitial nephritis as the diagnosis. So when the nephrologist can't figure out what the cause of AKI is and chooses to biopsy the patient, among those unknown causes of AKI, about 1 in 5 are interstitial nephritis. This isn't all AKI you see in the hospital. This is a very specific subset. What causes AIN? So this study is now 10 years old, but it's still, it's still representative with one exception. And so this is from Mayo Clinic, looking at 10 years worth of kidney biopsies with interstitial nephritis, and they found that all here are medications. So over 70% of AIN, and multiple studies have shown this, in the high-income world are caused by medications, things like antibiotics, proton pump inhibitors, and non-steroidals. In this data set, in the Mayo Clinic data set, the top 3 drugs that were responsible for AIN were omeprazole, amoxicillin, and ciprofloxacin. But if you look at folks who are younger, or folks who have autoimmune diseases, that's the second most common, about 20-25% of autoimmune. They tend to happen more in younger folks. And these are things like Sjogren and sarcoidosis and lupus and ANCA. There are little syndromes such as tubular interstitial nephritis with uveitis syndrome and IgG4-related kidney disease. So a whole bunch of things that can show up with that finding of interstitial nephritis. And then at least in the high-income world, infections form less than 5% of all AIN cases. Now, there's a big thing missing here, which is immune checkpoint inhibitors, right? Because this study is until 2011. Nowadays, immune checkpoint inhibitors have become a major cause of interstitial nephritis for us. So it was first described here, actually. One of the first papers was by Dr. Shirali, Parazella, and Gettinger in American Journal of Kidney Diseases, talking about a case series of patients who got interstitial nephritis while being on immune checkpoint inhibitors. And since then, multiple studies have come out talking about it. So a slight detour, and let's talk about AKI, acute kidney injury in immune checkpoint inhibitors. Like AKI for us is defined by a rise in creatinine. This is a study we did a couple of years ago looking at patients who were on immune checkpoint inhibitors at the Yale New Haven Hospital from 2013 to 19. And we found that almost a quarter of these patients developed AKI, AKI defined as, this KDIGO definition of AKI, which is 50% rise in creatinine from their baseline. About a quarter of them experienced that within the first year of starting therapy. And what does that mean for their outcomes? And so folks who got AKI in the first year tended to have almost a doubling in their mortality as compared to those who did not get AKI. And this association persisted even if we adjusted for all of these other things that might be associated with survival. And so AKI is associated with higher mortality in patients on immune checkpoint inhibitors. Others have looked at it and found similar numbers. So this is a paper from my collaborator, Megan Seiss at MGH. They looked at 1,000 patients on ICI therapy at MGH and found that 17% had AKI, 1.5 times baseline, during their follow-up period. And they found that the mean number of days that had passed since starting therapy was about 100. So about 3 months into their therapy, half the patients sort of developed AKI. They didn't have a lot of kidney biopsy, so we don't know what the AKI was from. What they did find was that if patients were already on a proton pump inhibitor before starting therapy, so this is a drug that I'll talk about in a second that we know is associated with AIN, then their risk of getting AKI was 2.8-fold higher. So, the conclusion was PPI use in ICI users is associated with an increased risk of getting acute kidney injury. We don't quite know what fraction of these 17% are actually an immune-related adverse event, AIN, whereas, the others might be other causes of AKI. So they have studies that have looked at this. And so they don't call it interstitial nephritis in these studies, but they call it ICI-associated AKI. So someone's looked at the chart and said, this AKI is from ICI use, and it's not from volume depletion, it's not from anything else. And if you look at these kind of studies, then about 1 to 4% of AKI is thought to be ICI AKI. So a smaller fraction than the 17% I showed you earlier. But what causes this ICI AKI? And so this is a study from Brigham and Women led by Shruti Gupta, who does a lot of work in this field. And she collected data from all over the world, actually. Folks sent data to her institution, and they had 429 selected cases of ICI-related AKI and 429 selected controls who never developed AKI. And they found that when these folks underwent a biopsy, so only about a third of them got a biopsy, but when they underwent a biopsy, most of them had interstitial nephritis as the cause of their AKI on the biopsy. So that's, the immune-related adverse event in the kidney. You can see here, the tallest bar here is acute interstitial nephritis. There are some other causes scattered around here. But far and about, if they get a biopsy, meaning the nephrologist can't figure out what the cause of AKI is and then do a biopsy, the diagnosis ends up being AIN. And when they compared these two groups, the ones who got AKI and the ones who didn't, again, proton pump inhibitor shows up. And so PPI use associated with 2.5-fold higher odds of getting AKI. Another interesting thing that comes out is this concomitant or prior immune-related adverse event, which we've found in other studies too. So if you're experiencing an immune adverse event in the skin, heart, et cetera, the risk of this AKI goes up. PPI association was also noted in that earlier study by Meg and Harish, where PPI use increased the odds of getting AKI here. Same thing in David Leaf's data. So a bunch of people have shown that being on a PPI increases the risk of acute kidney injury. The question always is, well, everyone takes a PPI. What is the data here? Do PPIs really cause AIN? Are the PPIs really associated with AIN independently of being just sick? Because PPI is a sickness marker. So the best evidence that I've found, at least, is from this group in Ontario. They looked at 290,000 patients, older Ontario residents, who were started on PPIs at hospital discharge, and they followed them up for 4 months for an outcome of AKI or AN. And they have pretty good follow-up in the Canadian data sets because everything is in the same system, the meds are available, et cetera. And they found that after starting PPI, the odds of AKI go up 2.5-fold. Odds of AIN on biopsy, so not all of these AKI get biopsy, but also AIN also go up. So there seems to be some strong association with of PPI use with both AKI and interstitial nephritis. In the general population, non-ICI users, and I showed you earlier, even in the ICI users. Based on this, an additional 0.2 cases per 1,000 person years diagnosed, with diagnosed AIN in PPI users. Well, so what do we do about it? Does stopping PPI make a difference? Or is this just association? And so the best evidence from that is from my colleague, Perry Wilson, who does a lot of this EHR work. And you've probably seen, if you take care of patients, his alerts that show up that, hey, your patient has AKI and is on a medication. So this is one of the trials he did here at Yale, where he told providers, when you try to put in an order, that, hey, your patient has an AKI and is also on a medication that is AKI related, peri-AKI, such as proton pump inhibitor, NSAID, and ACEs and ARBs. And what he found was that when they gave this alert, PPIs were discontinued at a rate that was 25% higher. So people stopped the PPIs when they got these alerts. And the composite outcome, progression of AKI dialysis and death, the only subgroup where it really mattered was those on PPI. So if you stopped, in this group, in the PPI using group, when they got the alert, PPIs were discontinued more often, and they had lower progression of AKI dialysis and death. And through some statistical wizardry, they figured out that of the overall effect, about 11% of the total effect, this was mediated through PPI cessation. So maybe after this study, which came out last year, now I'm okay saying that, hey, if your patient has AKI and they're on a PPI, you should probably switch it out based on these data. And then, I showed you that, 20% of US adults take PPIs. Not everyone gets AIN, not everyone gets AKI. A very small fraction gets AKI. And so the question always is, well, who gets it? Like, what are the risk factors? And the only good study that I've found on this is by this group from Beijing, from Peking University in Beijing, that looked at 544 kidney biopsy proven AIN with controls. And this may not be applicable to our population, but at least there's some preliminary evidence that there are some genetic risk factors for getting interstitial nephritis. And they found 2 genome-wide loci. And this one, to me, is the most significant here that kind of stands out. It's this particular allele in the HLA region that, variation in this allele is associated with a higher risk of getting AIN. And what they found was there was 4.2-fold higher odds of AIN if you had this allele. And they did some interesting work doing HLA imputation and figured out that there was the part that was really affected was this peptide binding groove of HLA-DRB1. It seems like the way you present antigens through this HLA region may affect who gets interstitial nephritis. Again, it needs to be, there's some, so the conclusion is there's some genetic predisposition to occurrence of ATIN. We need to do these studies in the US population before we can bring it to practice. But I think it's an interesting preliminary data to suggest that we can maybe figure out who'll get AIN if we put them on a proton pump inhibitor and maybe immune checkpoint inhibitor in the future. Okay, so let's see how we're doing on time here. So next part is, diagnostic testing in interstitial nephritis, which has been my focus for a while. So I'll present to you two cases that are, they're participants in this Yale kidney biobank that I guess I didn't mention at the top, but I've sort of enrolled participants in who are getting kidney biopsy in this Yale kidney biobank for the past about 9 years now, and we have 1,200 participants. And this is one of the cases from that, and I'll present two cases from this biobank. So this was a participant who had stage 4 non-small cell lung cancer on anti-PD-1 pembrolizumab, started about a month ago. Creatinine close to quadruple, so stage 3 AKI according to our KDIGO definitions. Sent it for IV fluids, creatinine continued to worsen. There was PPI started about a month before ICI. No other renal toxins. Urinalysis was there's nothing kind of write home about here in the urinalysis. There's some abnormalities, but nothing crazy. The nephrology team, consult team, when they saw this patient, saw tons of white blood cells, granular CAS, which could be ATN or AIN, NWBC CAS, which maybe is specific to AIN, no obstruction. They thought there was a high suspicion given the white cell CAS, and they said, all right, we'll still do a biopsy. We just want to make sure. And they do a biopsy, and you see this. This is even anyone can know this is interstitial nephritis with tons of immune cells. This was an easy diagnosis to make. This is interstitial nephritis. But let's look at another case. So this is another case from our biobank. Stage 4 non-small cell lung cancer, pembrolizumab, started 8 months ago now. Developed an immune-related adverse event, a rash, 4 months into treatment. Then a month ago, started getting worsening creatinine. The creatinine had gone up from 1.1 to 1.7. Slowish rise in creatinine, not really meeting the classic AKI definition, but still, has decent loss of kidney function. The nephrology note said that there was high suspicion of AIN, and they were willing to try treatment, but the patient didn't want to. He's like, this drug is working for me. By drug, he means immune checkpoint inhibitor. I don't want to stop it. Prove to me that this is the problem before I stop that drug, which I think is reasonable. There was some NSAID use. Patient said it was frequent. No PPI use, no other renal toxins. The blood EOs had gone up a touch. We think, sometimes blood EOs go up in AIN. This is UA, nothing really. Bland urine, no CAS crystals, and no obstruction. And so at patient's request, we did a biopsy, and this is what the biopsy showed. There's no interstitial nephritis. It's just all tubular injury. And we did nothing here. It's just, this is where his biopsy was, and just with conservative management, continuing his therapy, creatinine improved back to normal. And we're seeing more and more of this because now we're putting patients on immune checkpoint inhibitors and drugs that cause tubular injury. And so with those combination, we're seeing more and more of this tubular injury. And so when you're faced with a patient who gets AKI, this is the slide from Meg size, when you see a patient with AKI on immune checkpoint inhibitors, there's a whole bunch of things that you now have to think about. The one you worry about is interstitial nephritis, because that means that you had to put patients on steroids and stop their therapy, et cetera. And so this is the one we worry about. But there's a whole bunch of other things in the differential here. And so, the question is, for us as a nephrologist, when we see a patient with AKI, we're suspecting AIN, is what are some features that will tell us whether this patient has a high or low risk of AIN? And so, does lack of clinical features, fever and rash? So our second participant had no fever. First one didn't have any fever either, but he did have a rash. But if you didn't see any clinical features, does that rule out AIN? Does a slower loss of kidney function rule out AIN? So he had a rise in creatinine from 1.1 to 1.7 that took maybe about a month. It didn't just shoot up. Does that rule out AIN? We didn't see WBC CAS. We saw it in the first patient, but if you didn't see WBC CAS, does that rule out AIN? Should we be getting urine eosinophils? You can't even get it because the lab wouldn't do it for you anymore, which is good because I'll show you the data for it. Does presence of proteinuria, so maybe having a gram of protein in the urine, does that rule out AIN? Or is there no single non-invasive test that can reliably rule in or rule out interstitial nephritis? And let's look at each of these one at a time. So first is patients with AIN have no typical features. So this is again that that group from the Mayo Clinic. What they found was in that 100-some patients with interstitial nephritis, they reviewed the charts and they found that rash and fever were seen in nobody with PPI-induced AIN. We did see it with antibiotic, but again, not a lot. The classic triad, at least what I was taught in med school, fever, rash, and eosinophilia, nobody with PPI, and about 10%, 1 in 10 with antibiotics. And so these features to me are not great at ruling in or ruling out interstitial nephritis. And no wonder, because they had no features. The duration of drug exposure before diagnosis was 234 days in PPIs. Now, this was also a time where we didn't quite know. This is 20 years ago, where we didn't think PPIs were associated with AIN. Things have changed now. So we probably don't wait 234 days before we diagnose it. And because of this probably because of this long duration, recovery was much lower. Only a third of the patients with PPI had full recovery, and a third had no recovery of kidney function after interstitial nephritis. And so the lesson being absence of rash and fever does not rule out interstitial nephritis. What about loss of kidney function? Do you expect kidney function to just shoot up? Because remember, our second case had a slowish rise in his creatinine. And so this is a study that looked at 107 cases of biopsy-proven AIN, and they evaluated this KDIGO definition of AKI. So KDIGO definition is a 50% rise in creatinine in 7 days or a 0.3 rise in creatinine in 48 hours. So an abrupt loss of kidney function. And they found that just over a half of these had AKI before their biopsy, meeting that definition. The rest had some loss of kidney function. So they had this thing called acute kidney disease, which is a rise in creatinine that is slower over 3 months. We saw something similar in data that I'll present later. And so the way to think about it, at least for me and the way I tell trainees, is that in AIN, you could get this slower rise in creatinine, and then it just hangs out. Whereas ATN, you get a rapid rise and you either fix it or you don't. And so the one way, we shouldn't, if the creatinine is slowly rising, it's not always chronic kidney disease. You got to think of AIN. And so patients with AIN may present with subacute loss of kidney function. I think it's the lesson here. What about eosinophils? I saw your faces when I mentioned eosinophils. You kind of already know this, and so I'll sort of quickly go through this. But this is a study, again, out of that Mayo Clinic, a different paper. And they looked at 566 patients who'd gotten a kidney biopsy, 16% of whom had AIN. And 43% were antibiotic related. And they found that you see eosinophils. So the black is over 5% of urine eosinophils. Gray is 1 to 5%. And you see eosinophils in a whole bunch of diagnoses. You see it in crescentic GN. You see it in proliferative GN. You see it in some cases of AIN. But a bunch of AIN cases also have no eosinophils. This is less than 1%. And so you can see the test characteristics here, sensitivity, specificity, positive and negative likelihood ratios are not great. And based on this, there was an editorial which basically concluded that we shouldn't be ordering eosinophils. Now, this is 10 years old, and our lab has stopped doing it, so I don't even spend too much time talking about it. But if you're still taught that you should get eosinophils to diagnose AIN, you shouldn't do it. It's basically the conclusion. This is from when I started. Dr. Perazal was a program director. He basically concluded saying that it should signal an end to urine eosinophils as a useful marker for AIN and provide nephrologists with data to definitively recommend against this test. So most centers have stopped doing it. We can't even order it here. So it's not indicated. What about other urinalysis findings? Is there anything else in the urine that would point us one way or the other? So this is data from David Leaf's group at Brigham. And this is in immune checkpoint inhibitors. And they looked at folks who got acute kidney injury. So this is an AIN, but this is, that acute kidney injury that's severe. So it might be, and again, we don't know. But they found that about 40% of them had hematuria, 60% had no blood in the urine. Only half of them had white cells in the urine, at least by this leukocyte esterase, not by microscopy. But even by microscopy, they only had 50% with white cells that they were able to see in the urine. And 2/3 of them had very little proteinuria, less than 1+ proteinuria. So it's quite challenging to rely on any one factor. What about this? So this is, you can see this is a Highland matrix. This is a cast and there's cells in it. So this is a cellular cast and you can kind of tell that these are white cells. So this is a white cell cast. We often associate presence of white cell casts with interstitial nephritis. This is a group out of Italy that does a lot of work on urine microscopy. They're very good at this. They're better than most in looking at white cells. And they looked at cases of biopsy-prone interstitial nephritis, small study, it's a case series. They found that 57% had white cells on microscopy, similar to David Leaf's data that I showed you a second ago. 14%, only 14% had white cell casts in biopsy-proven AIN. So it's not, if it's there, maybe there is AIN, but it doesn't let you rule it out. It's not a very sensitive test for interstitial nephritis. And there's similar white blood cell casts reported in that Mayo Clinic series. Now, the caveat is that, if you saw white cell casts, maybe you'll just treat the patient and not biopsy them. But again, that's unknown in my mind. So it's not very sensitive for diagnosis of AIN. Okay, so I would conclude saying that there's no single test that can reliably rule in or rule out interstitial nephritis based on the data I showed you. And so no surprise that AIN diagnosis on biopsy is often a surprise. And so, our goal is, when someone presents to us with AKI or AKD, some acute, subacute loss of kidney function, we got to figure out if they have AIN of all of these other causes. And in that Muriti series from the Mayo Clinic, biopsy-prone AIN was suspected only 55% of the time before biopsy. So they looked at the charts, looked at what the nephrologist wrote in the note before the biopsy, and only half the time, close to half the time, they were right. AUC in our study, which I'll show you in a second, was 0.60 with, lower limit of 0.50. So, it's kind of a coin toss before the biopsy. Now, the thing to remember is that you only order a dangerous test. Kidney biopsy is risky. You only order a risky test when you're really not sure. So it's not surprising that the AUC is 0.5, but again, in these equivocal cases, we're not very good at knowing who has AIN before their biopsy. And what's the clinical implication? So if you delay your diagnosis while you're trying to do other things, it can cause permanent loss of kidney function, right? Inflammation with AIN often results in fibrosis. Half the patients don't recover kidney function after AIN. So, the more you delay, the worse the kidney function gets. But if you incorrectly assume AIN diagnosis, then you treat them with steroids, which have side effects, or withhold immune checkpoint inhibitors, which they really need, like our second case. And so, we really need better diagnostic models for interstitial nephritis. Some of the work we've done, at least in using currently available tests, combining the currently available tests, is this one study where we had data from all clinical biopsies, kidney biopsies at Yale, about 550 at Yale, and then we had a validation cohort at Indiana. And we had a couple of AIN biomarkers that I'll talk about in a second in this sub-study. Outcome was AIN histology, and we looked at 150 variables, structured variables that are available to us in the electronic health record. So this doesn't include imaging report, for example, or clinician notes. We didn't have natural language processing, but we had things like labs, medications, and all those things. And we used this feature selection algorithm called Lasso to figure out the top features associated with interstitial nephritis on the biopsy. And what we found was the combination of these four things: serum creatinine before the biopsy, mu to creatinine ratio, absence of proteinuria, and urine-specific gravity. These four gave us an AUC of 0.73 in our test set, meaning, in the training set, you figure out what the models are, you build a model, and in the test set, you take those model weights. You don't retrain the model. You take those model weights and you apply it. And the AUC here was 0.73, and it was the same in our 0.74 in the validation cohort. Again, taking the model weights, applying it to a completely different place. What this model has is that patients have a loss of kidney function, creatinine is high, have a low mu to creatinine ratio, a low specific gravity, and absence of proteinuria. Those are the features, and a specific combination of those features gave us an AUC of 0.73 for AIN diagnosis. And we looked at the charts to see what the clinicians saw before the biopsy, and the clinician's pre-biopsy AUC was 0.60, like I pointed out earlier. So this model already improves upon this by 0.13. So just a combination of those four things improved the AUC. We've kept working on it. This is unpublished, but again, this is data from Johns Hopkins, and then newer Yale data, and the AUC stays about the same using the same model weights. And we built this into this calculator that there's a warning here that you can't see, but only apply this in cases where you're thinking of doing a kidney biopsy, because that's the population we trained this on. And if you put in creatinine, BUN, specific gravity, their protein, and prevalence of AIN, it'll spit out a probability of AIN. And I found this at least useful when I can't biopsy a patient because they're on dual antiplatelet agent, for example. And at least gives me an idea. And it has a pretty high negative predictive value, so helps me rule out interstitial nephritis by plugging in these variables. And kind of hard to Google, but it's on our website. If you just search for our website, we have the calculator, or there's this QR code to look at it. What we've done with this model is, so yeah, it has high NPV, but it has a low positive predictive value. So we can only get the positive predictive value up to about 0.3 here. So a third of the time it rules in, but it's pretty good rollout. It has a high NPV, but low PPV. It doesn't have anything specific to capture the kidney inflammation that happens in AIN. So it has all these things that maybe AIN adjacent, ruling out other things, but it doesn't have any specific thing for AIN. And so again, the AUC is kind of stuck at 0.7 something because of that, I think. But what we've done with this model, at least, is test out an interesting hypothesis in immune checkpoint inhibitor patients. And so the question is, can this AIN diagnostic model help us phenotype AKI when patients with immune checkpoint inhibitor therapy get AKI? And so, I showed you earlier that over 20% of the patients experience AKI in the first year after immune checkpoint inhibitor, but we think maybe 1 to 3% of them truly have ICI causing AKI, meaning AIN. And there was, there's this thought that less severe immune-related adverse events, such as dermatitis, are associated with better survival. It tells you that your therapy is working like it should. And so there's so can we test this out in kidney? And so the question was, what is the effect of AIN on survival after ICI use? So what we did was we applied that AIN diagnostic index, the model, to the participants and classified them into this estimated AIN based on the model. And we set an artificial cutoff of 10%, saying that the 10% of the probabilities by the model will call them AIN, and the bottom 90% will call them other causes of AKI. And so out of 550, we didn't have urinalysis on a bunch, and so we excluded them, but we left with 36 with AIN and 320 without AIN. And we wanted to see if, first of all, does that make sense? Like, does this classification make sense? So we classified them. Those who our model said had AIN had a higher creatinine and higher BUNs, already at worse risk of outcomes because they're worse kidney failure, they're worse, BUN. The oncologists held their drug for longer, meaning that they really did think this was ICI related. This was a predicted probability based on the model. They were also coded as AIN 70% versus 5%. So again, there's some, evidence that this might be true classification. We also reviewed the charts, blinded to the diagnostic probability, and a nephrologist reviewing it, the treating clinician based on their notes, and this classification all agreed with what we thought was classified as AIN. And when they got a biopsy, the ones who had AIN on histology had a much higher AIN probability than those who had other diagnoses on the biopsy. This is a subset. So what did we see? We saw that patients who were predicted to have AIN had better survival than others with AKI. So this line is AIN, and this line is all the other AKI, non-AIN AKI. And you can see that there's 56% lower hazard of death in those who had AKI from AIN as compared to AKI from other causes. And when you compare it to those who never got AKI, there was no difference in at least, there's no significant difference in survival between these two groups. This is the no AKI group. This is AKI from AIN, and this is all AKI. So it sounds like we should probably, there's a couple of others, we did, when you do this kind of study, you want to slice and dice it every which way and make sure your findings stay consistent. And so we did a couple other things. We did this thing called landmark analysis, where you only include those who are alive at a particular landmark. Here we set it at 3 months. Same results. Those with AKI had worse survival. Those with, these are the AIN people, had the same survival as no AKI. We set an alternate cutoff. Instead of 10%, we set 3%. And again, same thing. This is AKI, this is no AKI, and this is AKI from AIN. And so the conclusion being, those with estimated AIN based on the model had better survival than others with AKI, and similar survival as those without AKI. And so it it maybe gives preliminary evidence that if we phenotype AKI a little bit better, we might be able to tie it to some outcomes. Again, this is all model-based, right? And the AUC of the model was only 0.73, 0.74. So how do we get that better? And so this is where a lot of my work has focused on is AI and biomarkers. But we're more than halfway through, and I'm going to maybe take a break, take a sip of water, and see if anyone has questions.
Other kinds of acute kidney injury that result in higher mortality. There's some knowledge as to what that is, and if the actual kidney injury is what's leading towards mortality in those cases, as opposed to other medical, either cancer or other conditions. That's
a very, very good point. And so anytime you look at AKI and mortality, AKI is associated with worse mortality. And my personal opinion is that, is that it's a canary in the coal mine. When someone gets AKI, it's telling you there's something else wrong with them. They have heart failure, they have cirrhosis, they've got sepsis. And so, yeah, it is a canary in the coal mine. And so that, I don't think it's the AKI that's leading to that mortality. But I think if the point is we shouldn't lump all AKI together when we do these big studies. We should try to phenotype AKI a little bit better because not all AKI is created equal.
Is there knowledge as to whether, let's say, if you're looking at non-small cell lung cancer as an example, whether it's the cancer-specific mortality is also worse in those, or that they're dying of other non-cancer causes?
Yeah, that was one of the limitations. We didn't specifically do chart review and try to figure out. I think that would be in the study that I'm showing you that we're starting off this summer. We'll do that. We'll do a chart review. We'll do an adjudicated cause of death. I think that's really important. Because you're right, it's, are they dying from, their heart failure, or are they dying from the cancer? I think that's really important. Awesome. All right, I'll keep moving. So, when I started off wanting to look at biomarkers of interstitial nephritis, I had a hypothesis to test, but what I didn't have is samples. And so there were no biobanks at that time when I started off in 2015 that had samples ready to test in patients who had biopsy-proven AIN and biopsy-proven controls. Because I told you, it's hard to diagnose AIN without a biopsy. And so I started recruiting when I was in my last year of fellowship into this biobank, what has turned into this Yale Kidney Biobank. And now we have over 1,200 participants with in a biorepository with samples, urine, blood, DNA, et cetera, and biopsies from these participants who have biopsy-prone diagnosis. And we've given out, it has helped me build my research program, but we've also given out tons of letters of support for grants. People have published manuscripts. We have a rapid peer review process, so we can equitably give out samples. So if you ever need samples from patients who have biopsy-prone diagnosis, reach out to me. I should have put a QR code for the form that you have to fill out, but just email me and I'll connect you with the right people. But anyway, so in this, the first hypothesis that I tested, this was part of my PhD in investigative medicine program, where we looked at, the hypothesis was that, there's a ton of CD4 positive T cells in there. And if you test cytokines from these CD4 positive T cells, maybe they'll be higher than those in other causes. So what we found was there were no difference the differences we found were in TNF-alpha and IL-9 of the 12 cytokines we tested. And you can see AIN here, this box and whisker plot with median interquartile range. AIN is higher as compared to all of these other things: tubular injury, GNs, diabetic kidney disease, fibrosis, other, and normals. And it's true for TNF-alpha and IL-9. No difference in plasma markers. So all the differences we saw were in the urine. And the AUC, when you added biomarkers to that AIN diagnostic index that I showed you earlier, got up to 0.84. But the challenges was that we only tested 12 cytokines. And so hypothesis-driven testing might have missed other more accurate biomarkers. The goal is getting a better biomarker. We might have missed it because of that. The other issue was, I realized later, is that cytokines are at a very low level in these samples because they have a high affinity for the receptors. You don't need too much of it. And so they don't serve as good biomarkers because it's hard to convert these into bedside tests because the level is so low. And so we kept looking. And so the next thing we did was, this is the most recent work where we took the same, Yale Kidney Biobank, everyone who had a kidney biopsy for loss of kidney function between these dates. We had 3 pathologists tell us whether or not the participant had AIN or not, so adjudicated diagnosis of AIN. And we classified them into AIN and controls. And we used, this is now 5 or 6 years ago, but this was at that time cutting edge. Now they can measure 5,000, but at that time we were able to do 184 proteins that were involved in inflammation and immune responses using this proximity extension assay with this company called Oling. And they report out these NPX units that are basically count values, like they run a PCR and you get a NPX unit count value from it. And we sent them a plate full of samples from AIN and controls. And what we saw was the thing that stood out. This is, the volcano plot, fold difference on this axis, p-value on a log scale on this axis. The one that stood out was CXCL9. It was 7.5-fold higher in AIN and controls and highly significant, even in our small sample size. You can also see TNF alpha here that I showed you earlier. It also shows up. It's maybe 1, 2, 3, 4, 5th here in terms of strength of association. But really, CXCL9, a chemokine that's downstream of interferon gamma. I was really interested in interferon gamma coming in because I thought that would be the top hit, but a third of interferon gamma samples were under detection. So I was quite excited to see CXCL9 show up as one of the top hits here. But obviously, this was proteomics from a newish company. Can we trust their results? So we compared their values with what we knew. This was an immunoassay using Mesoscale Discovery Platform. You saw a straight line, a correlation of 0.99. So you kind of have to compare this because you don't get a concentration from this. You get an NPX unit. And so we compared and it was great. We looked at, AIN and control in the whole cohort. So 31 cases of AIN and 173 controls. And you can see that, much higher levels in AIN than controls, much higher levels in AIN than all of the subtypes of controls. We had 4 patients only in this cohort on immune checkpoint inhibitors, 3 of whom had AIN and 1 had ATN. I think this was the case that I presented as case 2. And you can see that the ones who had AIN, again, this is not statistical testing. There's only 4 people here. They had much higher CXCL9 values, 312, 1485, and 1789 in nanogram per gram versus the ATI. So we want to test this out, obviously, in a much larger cohort. But again, preliminary evidence that maybe there's something here. We did some testing of independent association. So model 1 is univariable, model 2 is controlling for the clinician's pre-biopsy impression, and model 3 controls for that diagnostic index I talked about. 2 analyses here, per doubling of the biomarker level or in quartiles. And you can see that per doubling of urine CXCL9, there was a 40% higher odds of having AIN. The highest quartile had 6-fold higher odds than the baseline. And it's true for all of the analysis that we did. We controlled for demographics, comorbidities, TNF alpha IL-9, plasma CXCL9, and then these other 2 markers that are downstream of interferon gamma. And turns out CXCL9 was still the best biomarker after all of these analyses. Obviously, our discovery in the proteomics and the immunoassay were in the same cohort. So you want to see these results get replicated in another cohort. And so we collaborated with a couple, at Mount Sinai, Kirk Campbell, and C-Probe out of University of Michigan. And both of these were only able to give us 10 cases of AIN and 23 controls. This is, because there's no good biorepositories for this disease. People don't store samples from it. But you can see that AIN folks had way higher CXCL9 than non-AIN here. And the AUC in the external validation cohort was 0.94. I mean, you can kind of see based on even this that, that's the AUC. And fairly good test characteristics. For example, if I highlight this Youden index, which maximizes sensitivity and specificity, the cutoff was 23, just above that ATN patient I showed you earlier. At sensitivity specificity in the 90s, fairly good PPV and NPV, PPV of 82, NPV of 95. So I think we're pretty excited about this marker. The other thing we showed that where is it coming from? Is it coming from the kidney or is it just filtering out of the blood because kidney filters stuff? This is a nanostring for expression analysis, a collaboration with folks at MGH, including Bob Colvin, who's a pathologist and has a big repository of this. And we showed that the expression, this is on a log scale, so kind of, they kind of look squished together. But this is AIN, and these are all the controls, and it's much higher in AIN than all of the controls, 4-fold higher than controls in AIN versus ATI, AIN versus diabetic kidney disease, AIN versus control is 10-fold higher, and so on. It sounds like it's coming from the kidneys. We also, in the early analysis, controlled for the plasma levels, and still the urine was quite significantly associated. We don't know what cells in the kidney. That's upcoming work as to, what are the cells that are making CXCL9 or interferon gamma that's upstream of it, and maybe we can target those cells, but that remains to be done. In this nanostring data, we looked at the top 10 differentially expressed genes, and most of them are interferon gamma induced. like you look through this, including the receptor for CXCL9, which is here, CXCR3. So it seems like a lot of this is driven by interferon gamma, which kind of what we thought 9 years ago and finally are able to show here. Even in our urine proteomics pathway analysis, interferon gamma is the top activated gene. No surprise, because CXCL9 is a top biomarker. And so, this I was just talking to Dr. Rosenberg earlier, could we treat AIN better using, a bunch of these oral drugs that are now available to target the interferon gamma pathway, the JAK-STAT inhibitors, et cetera. Unanswered, but it's something that I want to do in the future. We're not the only ones who found this. Other groups around the same time that we're publishing our manuscript came up with the same sort of findings. And so this is a finding out of MD Anderson. They looked at, this is an immune checkpoint inhibitors looking at AIN, 9 patients with tissue, ATN, hypertension, and the top differential expression genes, if you look at the top 10, the 2, 3, and 4 are all interferon gamma induced, CXCL9 being here. Another study that came out around the same time that we were working on, with our manuscript had just come out, is this study looking at non-small cell lung cancer and melanoma. They enrolled patients at startup therapy, collected sequential samples, and what they found was that T cells proliferated within 1 to 2 weeks of starting therapy and started making CXCL9, a bunch of interferon gamma related proteins. And those who had higher expression of these tended to get more colitis, pneumonitis, skin stuff, hepatitis. There were 2 or 3 cases of nephritis buried in the supplement, but they were there. And so, quite reassuring that a bunch of, and this is, again, CXCL9 was much higher when they did proteomics in the serum here, not urine, but because they're looking at all of this other toxicity. So a bunch of, folks have stumbled on CXCL9 lately as a biomarker of immune-related adverse events. And so in the last 10 minutes, I want to talk about, because I worked on this for 9 years. My mentor has worked on AKI biomarkers for maybe 25. And, we don't have too many biomarkers for AKI, at the bedside. And so what we want to do is maybe try to get some of these markers into practice. So how do we get AI and biomarkers to clinical practice? We're academics, not a company, but we try, and maybe we can get some companies excited. But one of the things you need is something like this. You need external validation. You got to figure out cutoffs, association with treatment, temporal changes, drug subclasses. So I haven't, my first R01 that I got is on this. So we've enrolled over 1,000 participants now with kidney biopsy proven AI and our controls. We finished having pathology adjudication done, and the biomarker are getting measured now. And so hopefully by the end of this year, we'll have some more results to show. This kind of is the same setup as the FDA validation. So if a company is interested in FDA validating this might serve as data for them. The other thing that we're doing, so a lot of these data are in immune checkpoint inhibitors, and I've kind of alluded to the studies that we're going to start this summer. And so this is a multi-PI R01 that I have with Megan Seiss that hopefully we'll start this summer or fall, depending on what NIDDK wants to do with the funding. But here we're going to use CXCL9 to phenotype the AKI in those who are on immune checkpoint inhibitors and predict response to them. I'll talk a bit more about this. And then in this study, we also have this point of care test that I'm quite excited about that I'll show you. So, I don't need to, this is an oncology audience. I don't need to tell you too much about the challenges with AKI and immune checkpoint inhibitor, but, just briefly, there's no way to reliably differentiate ICI-AIN from other causes of AKI generally. If you wrongly assume it, patients get on steroids, the therapy is paused. We don't like that. If you delay or miss it, there's permanent kidney damage. They become, ineligible for more chemotherapy, et cetera. And once we diagnose AI, and at least the challenge for us is, well, when do we stop it? Are steroids working? Should we give them something else? And there's no biomarker of therapy response. And then for those who are, a third of the patients are steroid resistant, what do you do about them? We don't really know what the pathways are of why people fail steroids. And so different centers do different things. There are centers that do infliximab as a second line, some centers do CellCept, et cetera. And so there are quite a few unanswered questions. And so our goal in this study is to answer those 3 questions. So we have 4 sites, MGH, Brigham, Johns Hopkins, and Yale, where we'll enroll participants from. The goal is 400 participants enrolled at AKI. So our time point is AKI. We have an alert set up at all the centers where we get an alert when someone meets that AKI definition. We run to the bedside, whether it's clinic or the hospital, consent them, we get a bunch of samples from them, start following their EHR records. Aim one is to test the accuracy of CXCL9 in this immune checkpoint inhibitor population. Remember, I told you we only had 4 people with AIN in our prior cohort, four people on immune checkpoint inhibitor therapy on our prior cohort. We'll use both immunoassay and this lateral flow device that we developed. I'll show you in a second in the next slide what this device is. We'll also look at CXCL9 at follow-up and see if the CXCL9 change correlates with renal recovery. And then in AIM3, we have urine and plasma proteomics. So this is the basic design: enroll 400 patients through biopsy, if available, or adjudication. We'll figure out if they had AIN or not. And then we'll have, our hope is we'll have 100 patients with AIN, 300 without AIN. And we'll look at, CXCL9 levels at follow-up, proteomics, et cetera. And we have a lot, fairly large team. Meg and I are the PIs. We have 3 oncologists at each site. Dr. Kluger here, Kerry Reynolds at MGH, and Aliyah Pabani at Hopkins. JHU site PI is my former mentor, Chirag Parikh. Brigham and Women, we have Shruti Gupta, whose studies I showed you earlier. We have AKI adjudicators, so they'll have access to all the information now, but also in the future, what therapy the patient got and whether or not they responded. So hopefully with this future information, we'll be able to establish AIN versus not accurately, but that remains to be seen. And so we're hoping to kick off in the next month or so. So you'll see our team sort of running around and collecting samples at AKI. And this is the study that they're collecting samples for, just so you know. So what is this lateral flow device? And so we, with COVID, there are a lot of bad things with COVID, but one of the good things that came out of COVID was companies got really good at making these lateral flow devices. So it's these rapid antigen tests that you do at home. And there are a ton of companies that can now take your favorite biomarker and make you this lateral flow device dipstick. And this can be like this, or it can be a fluorescent base to improve sensitivity, et cetera. And so we worked with this company called Mologic, which is now part of Global Diagnostics. And they made this dipstick for us, where you can see here, these are 3 samples with arterial nephrosclerosis, so had very low CXCL9 level. This is AIN patient with a very high CXCL9 level. And you can see that AIN patient, samples from AIN participant has this test line here. This is the control. And they have, CXCL9 antibodies here. You can see, fairly nice linearity of dilution here. So as you go lower and lower, your eyes might not be able to see that faint line, but we have this optical reader that can read it. And so what's left to do is we've done this affinity. So this is we just picked any random pair of antibody and said, hey, test it out and see if it works. And so it did work, but we're not happy with the lower limit of detection. So then we did this affinity testing to figure out the best antibody. So they took all the available antibody pairs on the market, did some affinity testing, fancy algorithm, and came up, okay, well, this is the pair that'll work the best. And so now they're rebuilding the dipstick for us using that pair, which will improve the big problem here is the sensitivity. The lower limit of detection needs to be really low for this disease. And so they're redoing it for us. And I think what we'll have to do is convert this into a fluorescent dipstick. So you have a reader. You have the dipstick, you can't really see anything, but you have a reader, then you plug in the dipstick in it and it gives you a reading. And this is something that we can have in clinic, because this isn't lab tied. This isn't something that we have to send out and stuff. We could send out to the labs, but we haven't gotten too much excitement on measuring this in the lab. But this is something that we have access to at least test out in the real world and just give these dipsticks to our clinicians who can run it at the bedside. And so I think that's my last slide. To summarize, AIN diagnosis is challenging without a biopsy. I showed you lots of data on CXCL9 that we identified through urine proteomics and validated through immunoassay and external cohorts. Our ongoing work aims to further move biomarkers into practice through validation, application, and checkpoint inhibitors. I didn't show you the alert part that Perry's working on, tying CXCL9 with alerts, and this lateral flow device. I showed you this AIN diagnostic model and a brief application where high predicted probability, it helps us phenotype patients on immune checkpoint inhibitors who get AKI. And so with that, I'll end. Lots of people to thank. My email is not here, but my email is firstname.lastname@yale.edu, like all of you. So please reach out and yeah, I'm happy to take questions.
I can start. One of the things I was thinking about with a lot of the immune-related adverse events is that sometimes there's more than one. And, for instance, like your CXCL9, if it's urine that you're going from, it's presumably a lot more specific than plasma might be. But do you find, for instance, if a patient with colitis, that you have urine CXCL9 as a confounder in cases like that?
Yeah, it's a great question. We don't know is the answer. In our study, we won't exclude people who have other immune-related adverse events. We'll include them, but collect data on that. And so hopefully in the next, when we're done with this in 3 years, we'll know if CXCL9 is specific to, interstitial nephritis or is a marker of any odd immune-related adverse event. But that's a good question to answer, I think.
May actually also be on target anti-cancer efficacy, presumed to go up with that as well, right? So in plasma, not necessarily urine.
Right.
Another question I have is the HLA-DR DRB1 allele or SNP association in the GWAS testing. Is that associated with other immune-related adverse events aside from AIN, or is that specific?
I don't know is the answer. I don't think anyone's tested that. That group only took AIN in the general population and controls. I'm sure someone in the cancer world has done that. I just don't know.
I think it's more broad. We're interested in seeing what else in particular.
Yeah. There's a question over there. I'll take that question first and then go to Zoom.
My question was kind of following up on what Marcus mentioned in terms of the potential HLA class 2 with the genetic association. You mentioned there's a lot of CD4 T cells in the do you know if they're clonal and if it's different with depending on which one?
Yeah, it's a great question. One of my PhD mentors is Jordan Pobert, and he's always had that question, and he's always said, "Hey, could we sequence these T cells and try to figure out?" The only I didn't present this study. There was a paper 10-ish years ago now in JASN looking at regular old interstitial nephritis, not checkpoint interstitial nephritis, and they found that they didn't sequence it. This is long ago now, but they found that the T cells and the kidney biopsy and the PBMC produce the same type of cytokines. They should have, now we just sequence them and figure out, but I don't think they did that. But we haven't done it, but it's a great idea. All right, so let's see. Great talk. You're just simply a reflection of the secretions. Yeah, so Dr. Kluger is asking, can you tell if CXCL9 in the urine is simply a reflection of secretion of CXCL9 due to high circulating levels resulting from aggressive ICI treatment? Also, are you looking at use of anti-CTLA-4 concurrently with anti-PD-1 as a cofactor, given the CD4 cell role? Yeah, so Dr. Kluger, the first is, we had the same question as to, at least in our data, which had very few ICI patients. Our question was, is CXCL9 just getting filtered out from the blood, or is it coming from the kidneys? And a couple of ways we try to answer it. One was we controlled in our analysis, we had plasma levels. We controlled for the plasma levels and urine was still significant. That was one way. The other more specific way that we did it was that we showed that using nanostring, the expression of CXCL9 was higher in biopsies with AIN as compared to ATN, diabetic kidney disease, and other controls. We will kind of be able to do the same thing in our upcoming study, because we're collecting plasma levels, we're collecting urine levels, we'll enroll them if they get a biopsy. So we might be able to answer this in checkpoint as well, but that's a great thought. We are not, regarding your second question of CTLA-4 and PD-1, we're not excluding anybody. Anyone who's on ICI with CTLA-4, with other nephrotoxic agents, we're just enrolling all of them. The only people we're excluding are the ones who are already on steroids or other immunosuppression, because we feel like our biomarkers might not work as well if you've already gotten a bunch of steroids. But we are collecting data on them, and we'll be able to do the subgroup analysis if we can enroll enough participants.
Thanks.
Great.
So much.
Thank you. Thanks for the invitation.